Cup of Joe. We talk about healthcare topics. I'm joined again by my Chief of Staff, Ashley Bellew, and we're going to go over a new set of topics. This time we're going to talk about our favorite thing, insurance.
It's not my favorite.
Not
sure.
your favorite?
Not my favorite.
I don't think it's anybody's favorite. It's certainly not my favorite. I can assure you of that.
It's very confusing.
It's
At least for me, it's very confusing.
It's terribly confusing. I've never met a person who isn't confused about
Sure.
that. Even people that work in hospitals
Sure.
are confused about it.
Sure.
So let's try and clarify it to the best of our ability.
So first, can you explain what the difference is of being in network versus out of network?
Yeah. Each payer, Blue Cross, Medicare's a payer, Medicaid's a payer, Aetna, Cigna, et cetera, they develop a network of healthcare providers. A healthcare provider is a hospital, a doctor, physical therapy, imaging, labs. They have a whole network of all of these providers that are contracted with them.
Okay.
So believe it or not, you can be a provider of healthcare services in the United States and not be contracted with Medicare. You actually sign a contract with Medicare to provide care to Medicare patients following the rules.
That's interesting.
Yes. So all of these payers have networks of providers.
Okay.
And it's very uncommon for a provider not to have a contract with Medicare, though it is possible. But it's very common for a provider not to have a contract with a certain payer. And generally that occurs because they can't agree on pricing.
Okay.
Because each payer, Blue Cross, Aetna, Cigna, Medicare, sets their own prices. Now, Medicare and Medicaid do it by law.
Okay.
So if you accept a contract with Medicare and Medicaid, you accept their prices. There's no negotiating.
Okay.
But Blue Cross and Aetna and all these private payers, they have to negotiate with each provider to establish prices. And sometimes they don't agree on it. And in fact, in Houston, you have seen pretty much every major payer go out of network with one of the big boys at one point in time or another because they have reached an impasse in their contract negotiations.
Okay.
And then what you've found is eventually they come back together because the payers really need all the big networks.
Sure.
And the big hospital systems need the payers, so eventually they realize, hey, we've got to figure this out, and they come to some agreed upon terms.
Are they fairly competitive with each other?
Competitive in the sense that the prices at one? No. The bigger, more prestigious the provider is, the better the pricing is. So in the Houston area, MD Anderson has some of the highest pricing for cancer care of any hospital out there because they have the reputation to command the prices. If you look at on average the prices we pay, a Methodist has higher pricing than does Oak Bend, as an example. They're kind of the top of the tier for hospital systems. Then you have Memorial Hermann and HCA and St. Luke's kind of in the middle, and then you have the smaller operators like Oak Bend who have the least market power, and therefore our prices are lower because Blue Cross says, hey, we don't need you, so you're going to accept the rates that we give you, or you're just not going to be in network. Now, back on the question, in network is that they have a contract with the payer has a contract with the provider. Out of network, they don't.
Okay. So why would it matter to a patient if a hospital or a provider was in network versus out of network?
Well, if you go to an out-of-network provider, I did recently, my payer for the Oak Bend was no longer contracted with a certain hospital here in Houston, and I had to have a procedure there because my physician said that's where I want to do your procedure.
Okay.
Well, instead of paying, that procedure probably would have paid $10,000, $15,000, maybe $20,000 in network. Instead, it cost $60,000 out of network.
Wow.
So it's a lot more expensive to go to an out of network provider Now, fortunately, in my case, the payer paid it. I wouldn't have paid that much out of pocket myself, but if you want to go to a certain out-of-network provider and your payer will not pay for the care, then that comes out of your pocket.
So, okay, you said something recently, you said that your procedure, it was where the physician said for you to have it. But you have a choice as to where you could have your procedure? You don't have to go where the doctor specifically orders it?
Well, it's a very good question. There's a little negotiation that happens. Most physicians have privileges at multiple locations.
Okay.
And sometimes they have an incentive to take you to a certain setting where they may have an ownership interest.
Oh.
They're obligated to disclose that to you, though not everybody does.
Sure.
Not everybody understands what's being disclosed. But in my case, I could have chosen to have the procedure at one hospital at a certain time, or at another hospital several weeks later.
Oh, okay.
And so I chose, because of the procedure having some implications on my ability to travel, to have it at one hospital earlier than have it at another hospital. But I had that level of discretion with this particular surgeon. Now, it's ultimately the surgeon's decision as to whether they're comfortable operating on you in another setting.
Sure.
And then it becomes your decision. If you really want that surgeon to do your case, then you're going to have to do what the surgeon asks you to do in terms of choice of provider.
Because do you want your
But
surgeon
it's always your decision. It's always your decision as a patient.
What if it wasn't a procedure? What if it was labs or images, something like that? Do I still have that same choice?
So for testing, generally speaking, you can go wherever you want to go to get the testing done. So if you don't want to get the testing, so the classic example is we will pretty much all of us that live in the Houston area will eventually have to go down to the medical center for some reason or another to see a physician, a specialist physician that's not available in the communities where we live and work.
Sure.
So we go down to the medical center and the physician says, well, I need to do an MRI. And if you go to the front desk of that physician's office, they're almost always going to schedule you at the hospital with which that physician is associated, down in the medical center.
Sure.
So you live out in the Woodlands or out in Alvin or someplace way out there.
Way out there in Alvin. Yeah.
And now you have to go all the way back down to the medical center for an MRI. You don't. Okay. You can get that MRI at a whole variety of different places, and send the disc down to your doctor or bring it with you on your next appointment. And most doctors are going to be just fine with that. The same is true of lab tests. The same is true of other types of imaging studies, CT, X-ray, et cetera. There are a lot of different locations. But if you don't ask, hey, can you call this into my preferred MRI provider? If you don't ask for it, it's just going to default to what they always do, which is to order it at the local hospital where they work.
Is there anything I would need to do ahead of time, like if I chose to go somewhere else that my physician didn't order me to go, to verify like my coverage or anything before I took images somewhere else?
Well, yeah, I mean, the provider has to be in network, whether we're back on the earlier conversation, you're going to have to spend a lot more money to get it done on an out-of-network basis. Now, the doctor can write you an order to get an MRI or whatever the study is, or lab test. They don't have to call it in. So you can physically have a piece of paper that says, my doctor is ordering these tests. Okay. And you can then call around to find a provider. And different providers have, like I said, different prices. Okay. And so that affects your out of pocket. So you can call up Methodist and they're going to tell you, based upon the order, what your portion, the patient portion, is going to be of the procedure.
Based on my insurance.
Based on your insurance and based on your status with your insurance. In other words, if you have met your deductible, because it's all out of your pocket at the beginning of the year.
Sure, sure.
And some people have high deductibles, so it's big time out of your pocket until that deductible is met. So you really can have pretty sizable differences in the cost of a test based upon the facility, the hospital, the provider you go to.
So, talking about going, anywhere to do, imaging, there are so many of those freestanding imaging centers that you
They're
see
everywhere, aren't they?
everywhere. What are some of the pros and cons for those as opposed to an imaging department in a hospital?
So, generally speaking, this is not true universally, but generally speaking, hospitals are run under tighter standards for everything.
Okay.
From imaging to lab to safety in the OR, everything is tighter, more strictly overseen in a hospital than in an outpatient freestanding setting.
Okay.
Whether it's a surgery center, whether it's an imaging center, whether it's an independent lab. And I'm not talking about Quest and those guys. Those are big, giant reference labs, and they're very, very good at their work. And so if you go to an outpatient freestanding imaging center, there's three things that you're likely to encounter. So first of all, you got to imagine the really, really sick people are being treated in hospitals. So the really, really complex issues are being handled by hospital imaging departments.
Okay.
They're accustomed to that. The equipment is designed for that. The staff are trained to do that, are accustomed to doing it, and the doctors who read the studies and interpret them are all dealing with these complex issues all the time. You go to a freestanding, that's generally not where the sickest people go.
It's true. That's a good point.
So it's on average a healthier person that is going into a freestanding imaging center. Not all the time, but on average.
Sure.
And so all the things that I just described, you may have older equipment. The equipment may not be as well maintained as a hospital. The staff may be well trained, but may not be trained in dealing with complex issues. And same is true of the doctor. They may be trained in it, but they're just not accustomed to seeing complex issues. So if you end up in a freestanding imaging center and a complex issue is actually the underlying problem that comes, that should be picked up, it may or may not get picked up.
Okay.
It's just a different level of intensity of services, and the quality of everything that goes along with it is just different in an outpatient. Now, you're going in for, I've been told that imaging studies are not nearly as definitive as we think they are as lay people. As average customer thinks, I get an MRI, they can tell me exactly what's wrong. And what I've been told by a number of doctors is there's a lot of interpretation that has to be done, because you're looking at images from different angles and you're trying to interpret what you're seeing. And it's not as cut and dried as looking at an X-ray and seeing a broken bone.
That makes sense.
Okay. And so that's the issue with imaging is if the imaging tech, the MRI technician, doesn't position you right, doesn't get you to hold your position right, then the study results come out and are much less clear. Sure. Making it difficult for the doctor to make a clear decision as to what's going on. Okay. I tell people all the time, go to hospitals as much as you can, because they're just they're a safer environment.
That makes sense. That kind of goes back to our conversation about picking a ER always over a freestanding ER or urgent care. Things like that. Yeah. Okay, so I know I got us off topic a little bit.
Oh, that's okay.
We went down another
we're just
rabbit hole.
Around.
So going back to our initial conversation, like from a hospital's perspective, what are some of the challenges of staying in network with multiple providers, like specifically for Oak Bend?
The payers, you said providers, I think you're referring to payers. The payers always want to pay less for anything. Okay. As a smaller organization, which doesn't have the market power than the bigger organizations do, we have to almost beg them and say, look, we can't do without a Blue Cross contract. Sure. But you can basically impose on us any rates you want to, because we have no market power. And I literally ask them, I says, we're a safety net organization. We provide valuable services to our community. I'm not asking you to pay us more than you pay the big boys, but I'm
Sure.
asking you to pay us something in the same range as you pay the big boys. So it's really difficult. You really have to appeal to their to their compassionate side. Do I want to push? And this is true across the country. We're seeing smaller hospitals go out of business routinely because they don't have the market power to push back on the payers and say, that's not a reasonable rate. I can't make ends meet at that rate.
It's crazy to me that, using Blue Cross as an example, that they could charge us one thing for the exact same thing and they're going to charge it differently to any other organization.
Yeah.
It doesn't make sense to me. That part still doesn't make sense. And not just Blue Cross, but any payer. Like how do the rates differ like that, location to location?
Well, it's so I'll use a different example. If you are so let me think of something that you're familiar with. Your husband is in the trucking industry, right? And do they charge everybody? And so he's providing trucking services to customers. So would they charge less per load to a big giant customer?
No, I mean the rate is the rate. Yeah.
Okay, well that's different. A lot of businesses, like if I go into a store and I tell them I want to buy 1,000 units of a particular product, I'm going to get a better price than if I buy one.
So that would be different. I mean, for like looking at it from like a marketing perspective, whenever we purchase items, if you buy in bulk, the more you buy, the less you're going to pay per item. Yes. So I guess that's similar to how insurance works then?
Yes. So think about it. Methodist is a huge provider of medical services, and they have a lot of respect in the community as a whole.
Okay.
So people want to go to Methodist. And so Blue Cross has to negotiate a different way with Methodist than they do with Oak Bend because people want to go to Methodist. And so if you're an ExxonMobil, can you offer your employees a health insurance product that doesn't include Methodist?
Wow.
Not easily.
No.
Your employees won't like it.
Right.
And so that gives the bigger boys a market advantage.
Right. Interesting. So how does being in network align with Oak Bend's mission to provide, accessible and affordable care to our community?
Well, if we were out of network, we would, as we talked about earlier, be charging the patient much higher rates for their care. And we're talking emergency department services, and that doesn't fit with our mission. Our mission is to provide affordable care to the very best of our ability. So in network is the only way to go for us.
Do we do anything to improve transparency or to help our patients avoid any surprise bills at the end?
So there is a law on the books in Texas and the U.S. That goes under different names, but basically it's a No Surprises Act.
Okay.
So if you go in for a surgical procedure, for example, we're going to give you a good faith estimate of what the cost is going to be. And I don't remember exactly the specifics of it, but we have to get within a certain range of the ultimate price, unless things change dramatically from the time that we give you the pricing. In other words, if we go into your belly to do what is looked like to be a simple procedure and it turns out to be much more complex, the pricing can change.
Sure.
But we're going to give you a good faith estimate based upon the diagnosis and the plan of care, the procedure, et cetera, et cetera. And we're obligated to stay within a certain range of what the ultimate price becomes. Now, we'll call up the payer and we'll tell them, hey, this is the procedure, and they'll confirm like where you are in your deductible and things of that nature. So we do our very best. When you have to go into a hospital in an emergency situation, then there's also rules on the books that make it difficult for providers to charge you more than you would pay in an in-network ER versus an out-of-network ER. So they try and protect you from getting a huge giant bill. that you can't afford.
Why are the bills so huge?
Oh, okay. Yes. This is a byproduct of healthcare legislation. So when this goes back to the 60s.
Wow. Okay.
So when Medicare and Medicaid were established, at the time, you would get a bill from your doctor or the hospital, and you would pay it just like you pay for anything. You go to the grocery store, you pay what's on the price, right?
Sure.
Well, that used to be the way healthcare was paid for.
Okay.
And then Medicare and Medicaid came along, and they said, well, we'll pay the same way that you pay for Blue Cross. And everybody figured it out, everybody in the healthcare industry figured out that if they increase their prices, then they make more money. And since there were no laws that stopped them from doing that, they just increased their prices. And because Blue Cross and all those guys paid whatever they were charged, everybody increased their prices until the government started making laws that said, no, you can't increase your prices and make more money. We're going to do some auditing to make sure you're not making unfair profits off of the government.
Okay.
And then over the course of time that occurred, but there were still always these gaps where if you increased your prices, you would make more money and nothing stopped you.
That's crazy.
Right. And so, for example, 10 years ago, out of network, maybe 5 years ago, 10 years ago, out of network ERs were a big thing. So our prices in most hospitals are around 4 times what Medicare pays around. Okay. Some hospitals in different parts of the country go up to 10 times. But these freestanding ERs would set their prices at 20 times what Medicare pays. Because it could. Nobody said you didn't. Now, they wouldn't get paid 20 times.
Okay.
But at the time, most employers had insurance plans that said we will pay 50% of charges on an out-of-network basis. Well, 50% of 20 times Medicare is 10 times Medicare, right?
Wow. Right. If you say so.
Well, half of 20 times Medicare is 10 times Medicare, right?
Okay.
So they were getting paid 10 times Medicare. Most hospitals get paid, 1.5 to 3 times Medicare.
Wow.
So these out-of-network players were getting paid 10 times Medicare. That's why they jacked up their prices so high. So they would get the maximum out of this 50% of charges is our word for prices.
Okay.
So we just increase prices. Now that the payers have gotten smart about this, they make me, the hospital, give them an annual report if we've increased prices.
Okay.
And then they make adjustments in any services that are tied to prices. They make an adjustment so that there's no change in what they pay.
Interesting.
So we haven't increased prices across the board for 10 years probably.
Okay.
Because it just doesn't pay.
So why is it, like, I'll use myself as an example. Like when I had my son, why did I get so many different bills? You have the facility bill, and then you have a physician bill, and then you have an anesthesia bill, and then you have a lab bill, and then you have a radiology. And then my son, he got a whole set of these same bills. And why? Like, why are there so many? Does that make sense?
Yes.
What I'm asking? Okay.
Well, I can't speak for every state in the country, but the underlying issue is that each of these providers that you described are independent businesses.
Okay.
So in the state of Texas, hospitals are not allowed to employ doctors except in rural parts of the state.
Okay.
And so the hospital can't send you a bill for the physician services. And so we have, and most hospitals have, a separate business that provides us anesthesia services, a separate business that provides us surgical services, a separate business that provides us laboratory doctor or pathologist. So each of these independent businesses bills for their services. Instead of you getting one bill, it's ironic. We were talking about this as we prepared for this conversation. If you go into get your car repaired, you're not going to get a separate bill from the air conditioner mechanic,
Right.
from the transmission mechanic, or whatever needs to be done to your car. You get one bill from the repair shop that encompasses everything. Yeah. Well, medicine's not built that way. We're all different businesses, now there's some states that allow hospitals to employ doctors, and I don't know if they send one bill in those states. But whether you get a bunch of different bills or you get one bill with everything on it, it's going to end up still being, if you got 10 different physicians that have to do something, you go and see your pulmonologist, your cardiologist, your general practitioner, your orthopedic surgeon. If you have 10 different doctors that do something, you're going to get billed for 10 different
that makes sense
line items of service.
You're just seeing them all at one time whenever you go to the hospital.
Yeah.
Okay.
Instead of one big long bill, you're getting a lot of little bills, and it pull your hair out.
It's tough either way. So
I kind of would prefer it on one big bill. That way, I have one check I write, and I'm done with it.
Right.
But
so
that's not our system in Texas. And they keep on coming. And sometimes they come a year later.
Right.
They get lost in the provider system, and then they send you a bill, and you say, "Wait, whoa! This is a year ago." Like, I'm sorry, we lost it. We still need you to pay it.
So, what advice would you give somebody that really wants to be proactive in understanding what coverage they have?
Well, you have to call around. You have to you can ask your payer.
Okay.
You can ask Blue Cross, tell me where's the most economic place to go. They may or may not tell you, but you have to call around.
Okay.
And then you have to make an informed decision. As I told you, I'm a big advocate that all surgical procedures be done. I shouldn't say all, but most should be done in hospitals. Sure. Because it's an environment, it's a safer environment.
Sure.
Not to say that a surgery center is going to do harm to you. It's just it's not. They don't have an emergency department, for example, in the surgery center. So if something happens in the course of a procedure, they got to put you in an ambulance.
Yeah, it's true. That's true.
But it costs more. It costs more to go to a hospital than to the surgery center.
But you're paying for quality.
You're paying for quality.
Okay.
Absolutely.
That makes sense.
Yeah. So. But you call around.
Okay.
For example, you can, like these freestanding MRI facilities, their prices are half or what a hospital charges or less. And so if you're really tight for money, then it is in your best interest to just roll the dice and hope that you don't have something that gets missed in that setting that would be picked up in a hospital. Sure. Especially if you've not met your deductible.
For sure.
Yeah.
So you probably see a lot more procedures around this time of the year.
Yeah.
Around end of the year.
We get a lot of surgical procedures at the end of the year, diagnostic stuff, expensive stuff, because
elective.
Yeah, the elective work happens at the end of the year. If you have an emergency, your emergency is emergency. That doesn't. There's no rhyme or reason to that in terms of when it happens in the course of a year. But
makes sense.
But yeah.
Well, as always, this has been very informative. Clarified a lot for me.
I think I confused a few people, but that's okay.
I'm less confused going out than I was coming in. So
good.
Thank you.
Okay. It's a pleasure. Yeah. And thank you all for joining us today. I hope we shared something of value, and join us for another cup of Joe, and we'll continue talking about these topics.